things, and within our group we have seen a variety of presentations around strength, around stiffness, around instability and past histories of that. So now we're going to start to delve into that a little bit more now and start to think about knee stiffness. So in the concept of knee stiffness, and we were all very comfortable when we looked at an elderly person, we went straight away to osteoarthritis, knee stiffness. Now, knee stiffness and knee osteoarthritis is a spectrum, obviously. So for that elderly person to have knee stiffness when they're in their 70s, 80s, whatever it is, it probably started developing many years before that. It's not an immediate, it just didn't turn up. So they will have early changes. So seeing those younger people earlier in their lifespan, you might recognise that they have early stiffness changes, and that might influence your management at the time. So what do we do with that? Well, first of all, let's talk about what is a problem. What is knee osteoarthritis? It is characterised by knee pain and functional limitation. It's a clinical diagnosis. We don't routinely scan, and the clinical practice guidelines, which I've got in your notes as well for your reference, the clinical practice guidelines do not recommend that you routinely image to diagnose someone with knee osteoarthritis. Most of the time it's a clinical diagnosis. Usually people over 45 years of age, so talking about that spectrum, that's a lot younger, isn't it, than we're talking about the person that we saw, the nice elderly couple holding hands. It's different. That's activity-related joint pain, and their morning stiffness is relatively short. So when would you think that their morning stiffness would last longer? What conditions are you screening in your head then?
Rheumatoid.
Sorry, what was that?
Rheumatoid.
Rheumatoid, or some more systemic inflammatory conditions, yeah. So that tends to last more than 30 minutes. So osteoarthritis, 30 minutes or less. So imaging, not routinely used, but may be used if the presentation is atypical or they're trying to rule out another bony pathology, red flag. If there's any history of trauma. On one of the clinical guidelines we're coming up, it says there's no signs of redness. So in osteoarthritis, the joint isn't hot and swollen, so that might suggest that there's an underlying infection. That's when you would look towards other imaging or other investigations. The clinical practice guidelines for management of arthritis, including knee osteoarthritis, were updated in 2023. So those are recent updates and recent recommendations that we're going through here. So again, to give you the reference papers for this is again goes that, I'm not saying his name right, their name right, sorry, I'm sure. Duong, is that what we're going to say? 23, in that Dharma again talks through the process of osteoarthritis, a chronic joint disorder manifesting as structural and functional failure of the synovial joint. So in knee osteoarthritis, functional limitation. So we've got 3 different clinical practice guidelines, the EULAR, the ACR and the NICE guidelines. And the NICE guidelines are the ones that were specifically updated last year. The new recommendations that they have in the NICE guidelines, which is this is the BMJ summary of it, is that weight management has not been a specific recommendation in previous guidelines, even though it's recognised that if you're lighter on your knees, then you can have a reduction in pain. We'll talk about those guidelines a little bit more once we get past the surgical management. Okay, so total knee replacement is the surgical management for knee osteoarthritis. It can be, total knee replacement, you can have a hemiarthroplasty first. And my discussion with orthopaedic surgeons is often that just extends the life of the knee before they go to a total knee replacement. They'll probably have a total knee replacement in the future. It's to be considered if joint health is impacting their quality of life. So a person might be told by a surgeon, come back when you just can't stand it anymore and then I'll replace your knee. Now that person might persist with their knee, but they'll stop doing any physical activity, so they tend to put on weight. They stop socialising, so it affects their mood and affects their quality of life. And their pain progressively gets worse with the loss of strength and function around their knee. So then they go back to the surgeon. They've managed that maybe the stiffness and pain to a degree, but their quality of life has plummeted because they basically have stopped doing everything that's fun. So you need to consider that quality of life conversation with discussions around surgery. Do they still have quality of life? That's equally as important, if not more, than some of the other things. So outcomes and significant meaningful improvement. In 80% of cases, we have total knee replacements. In their pain, their knee function, their quality of life and their overall satisfaction. For 20% of patients, it doesn't improve their pain. So that sort of highlights that not everybody who has a total knee replacement is really a candidate for a total knee replacement. You've removed the joint, which you said is the source of their problem, put in a new one, and found out it's not the source of their problem, which would be annoying, wouldn't it? So, the medical management, that's what we were talking about. The guidelines have updated. These are the NICE guidelines, updated in 2023. Medical management is multifactorial. Education about what is arthritis. It's a change over time of your joint, which can be symptomatic or not. It's the body's response to load. It's actually the body's response to try and make more bone and adapt to the load, but it gets to the point where it can't do that. There are benefits and limitations of this treatment options, including surgery. And the first line is to manage symptoms. So what we're trying to do initially is to take away their pain and improve their function. Weight management is really important. Now this is a difficult conversation to have, and I think also it depends on your rapport with your client. So as a physiotherapist, I would hope that the GPs have already initiated that conversation for someone with knee osteoarthritis if they're in an unhealthy weight range. Now, not everybody is, but if they are in an unhealthy weight range, you would hope that the medical practitioner has already initiated those conversations. And it may be that the patient initiates those conversations with you and says, oh, I know I'm too heavy. But from a physiotherapy point of view, if you go in and say, you just need to lose weight, you've lost them as a client. They don't, and I've had many people say this to me, I'm sick of people telling me I'm just too fat. Yeah, I know. So if that's all you've got to offer as a physio, then you're going to lose them. And it's disheartening because, as we all know, I know, it takes effort and time to lose weight. It's hard to do, particularly if you're not particularly mobile on your knees. So I think our role, hopefully the GP has initiated that conversation. Our role is to support that conversation potentially. If they bring it up and say, look, I know I could lose a few kilos, you might say, so do you have any strategies in place around that? Have you spoken to anybody? Do you want me to give you a name of a dietitian? Is that something you'd like to explore? Be facilitating in trying to initiate a positive pathway. But that's not the only thing that we can do. So back to the doctor. So any weight loss is helpful. 10% has been shown to reduce their pain scores by about 50%. So it's really can give a significant improvement in their knee osteoarthritis change. But any weight loss can be helpful. The doctors can prescribe anti-inflammatories and simple analgesics for management of symptoms. And their education should support facilitating function and exercise. They can use injection therapies, So corticosteroid injection can be helpful for short-term relief. So in the context of, they've got a grotty joint, their joint surfaces are not pristine, they're not going to get better. We're trying to hold them. There is some evidence perhaps that a cortisone injection to a degenerative joint may accelerate degenerative joint change. However, if someone is in their 70s and they've planned a European vacation and they're going to be on their feet, walking around the churches for 6 weeks, and they just want their knee to feel better, then a cortisone is a very viable option to give them that window to enable them to do that activity. And interestingly, I have had plenty of clients who have gone on holidays where they've been on their feet more than they would be in their normal everyday life, and their knee has felt better.
They lose weight.
Well, I don't know. Yeah, they eat as well. I don't know about you. I come back from Europe probably weight neutral. Lots of food in, lots of steps out. But yeah, if they're doing more activity, they often come back and almost a little bit surprised. I'm like, actually, my knee was really good. So that's an interesting doorway of conversation too. You know, facilitating function and exercise, they did more, and my response to that would be, that's awesome. What does that say to you? And try to keep them on that role then. Yeah.
There was like a study a few years ago, I think, and it was about ultra runners. And they run from Berlin to Rome. And yeah, and they measured. They wanted to do it in one piece almost. So they took pictures of the cartilage inside their knees, and they saw the first few days they saw it shrinking, and then it started to heal again. And it was after 1 or 2 weeks after they run 8 days straight, there was almost no cartilage damage anymore. So it might also be for those people to start activating it a bit more. That's also some recovery take place.
Cartilage does respond. So, you know, people say to you, oh, running, it just wears your knees out. No, we know running does not wear your knees out. Ultras and marathon runners, potentially if you're at the high end of running, yes, you can have changes to your knee, joint surfaces and cartilage and thinning of the cartilage. If you're in the sedentary bracket, you get the same changes. So it's like everything, isn't it? Everything in moderation. It's that middle ground. You actually get thicker articular cartilage. So it responds to the load. It's a positive thing. And so runners generally have thicker articular cartilage of their knee. You're not wearing them out. You're making them stronger, and you're giving the cells a response. So they go, okay, so you want to use this, I better get thicker, I better get going. And they actually respond to it. So having that knowledge base to be able to say, actually, what the research tells us is that you're actually better off being on your feet. It responds positively. So with injection therapy, there's no recommendation in the guidelines for hyaluronic acid or platelet-rich plasma injections. And I know we discussed that about people finding some benefit of that, but the clinical practice guidelines, which look at all the research and consensus, says there isn't any indication for that in management. Okay, so from a physiotherapy point of view, what can we do? So we're talking knee stiffness and in the context of knee osteoarthritis. Now that can be patellofemoral as well. So tibiofemoral osteoarthritis, I think we can visualise a little bit more. You can see people have changes to how their knees are angled and potentially how they weight bear through their knees. But patellofemoral pain osteoarthritis can give you, you're going to be managing similarly. Okay, so education, address those psycho and social components to this. It's really important that we give context and encourage beliefs in a positive direction. Manual therapy for stiff knees, exercise and dynamic mobility to encourage that movement in the knees, and strength and load management. So, if we go through each of those particularly, now I want to refer you to this paper by J.P. Pinero, who works with, he owns practice with Peter O'Sullivan, who you're probably aware of, around back pain. And JP's done a lot of work around knees and works in the domain of knee osteoarthritis now. But it is sometimes difficult to know the correct way to respond to those strong beliefs that are held around knee osteoarthritis and what they should and shouldn't do. So again, you'll need your PowerPoints to zoom out on this one, but trying to give some balanced information, you are informing, you are not giving your bias here. We're giving balanced information around the messages that people are receiving. So what we need to say is that education, exercise therapy and weight management are the best osteoarthritis treatments to start with. A lot of people get some really good results with this, and it should be trialled before any surgical progression. And you can also say to people, and if you start this process, even if you do progress to a total knee replacement, that's okay, because now you've got a better baseline for your recovery on the other side. You're a little bit lighter, you're a bit stronger, you're a bit healthier, you've got better cardiovascular fitness. So you're priming them. You could see there's a prehab program also, almost. Joint replacement surgery is not necessarily the last resort. It is an effective treatment for the right case, but we do want to have an adequate treatment trial of conservative management first to see how much better someone can get with that approach. And maybe they get a bit better, but they may still progress to a total knee replacement. That's okay. Maybe it helps them manage their knee pain for a longer amount of time until they can time a total knee replacement where they have good social support around them, or they don't have to be at work, or their other partner doesn't require their care, or whatever it is. There are things going on in life, and if you can help people manage around it, then you can help support them to have a total knee replacement when it suits them a little bit better. Now, from an understanding the pain process, imaging results are poorly related to pain. You can have someone who has quite a large degree of pain and minimal changes on their scan. And conversely, you can have someone who has minimal pain but really quite significant changes on their scan. So it doesn't always correlate. And remembering we showed that picture yesterday with all the sources of pain around the knee, the soft tissues, the synovium, the fat pad, is often the driver of the pain. So if you can settle things down a little bit from a soft tissue point of view, it can help settle their pain overall on their knee. Pain does not mean you have damaged or are damaging your joint. It's a feedback loop. It's giving you some information about what you're doing, and we need to think about how we're going to respond to that. Now, every time that pain is stimulated, it doesn't have to be a mechanical stimulus, and if there's a strong inflammatory environment in your body, for example, if you're carrying extra weight or you have other systemic conditions, or if your mood is affected and mood is affecting your pain inhibitory mechanisms, then your knee pain can be driven up. Pain it doesn't mean anything's happening at your knee. Does that make sense? So there may be other things that you need to manage as well as managing the knee itself. And you need to put into context the pain that they're feeling at the time. Joints are strong. They're designed to take the load. So they respond well when you put load into them. They adapt to that. If you take load away from it, they actually weaken. So it is important to trust that the joint is going to take your load. You're not going to snap it, you're not that fragile. And you're going to progress better if you continue to put load through the joint. So that sort of leads into the next one, the importance of exercise. How many times have you heard or said, and you don't have to put a show of hands here, but said to someone, if your exercise hurts, just stop that exercise? That's something we need to reframe in our own minds for our own biases. Feeling uncomfortable, maybe feeling some pain in an exercise is not an abnormal response. It's something new. So if in a non-painful population, I told you to go and run 15 Ks as hard and fast as you could, the next day, would you expect to be sore? Yes. It's something different. You'd expect your quads to hurt, your glutes to hurt, your calves to hurt, whatever. Your joints to hurt. It's an input into your system, and it needs to take a moment to decide whether it's happy with that input or not. So monitoring pain as a response to increased loading is not necessarily a great way of going about it. What we want to know is the exercise is safe, and you have checked them for this before you've even given them the exercise. And you've also practiced it with them to make sure that they're doing it well. You've given parameters. Now you might say, okay, I'd like you to go and do this exercise. Particularly the first time when you do it, it's okay to have a pain level, and you can discuss what that might be. But it's okay if you have a pain level around 2 or 3 while you do this exercise. What I would expect is when you stop the exercise, it will modify, it'll probably go down pretty quickly. And next day you shouldn't feel that. And then the next time you try the exercise, it should feel a little bit easier and a little bit better, and the body will adapt to that load that you're putting into it. If the exercise is painful, it continues to increase being painful while they're doing it. It's sore afterward, there's a reaction of the joint, the knee swells. Okay, that's not a great reaction. So then you might say, okay, don't do that one. We're going to modify and do something else. But it is normal to expect a response from the body to say, this is a different input. I'm not sure my danger system's wound up around my knee because I know I've got osteoarthritis and it's been painful and sore to go up and down stairs. So you're really paying attention to do that. So that conversation and the language and the biases that we have can feed someone's fear avoidant behaviour. And if you always stop every time you feel something when you do exercise, you will never go into exercise, you will never get stronger, you will never go further. You will keep decreasing, 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 and so will your function and so will your strength. Does that make sense? Exercise helps people with osteoarthritis. It's good for your joints. You do not get more osteoarthritis by being more physically active. So that conversation about runners, it's a good example to give. But, you know, they might not be a running population, but they can relate to the story of putting load through your joints and how they respond. Which leads into the next one. Running with osteoarthritis is okay. You just need to monitor your symptoms and your response to that load. You may need to modify it. You may need to have more recovery days. So who's the runner here? Who runs? Who runs on consecutive days? So Monday, Tuesday, Wednesday, Thursday. Who has a day off in between? Yeah. So generally you're load managing. Some runners, really good runners, and their body type, you're used to it, can run every day of the week. And certainly in the marathon runners and the higher level runners, you've got to fit a volume in, so you end up running, the ultras runners end up running twice a day. So yeah, they've trained themselves up to that. However, mostly when we're running, we have a day of running and a day of cross-training, day of running, day of cross-training, or a day of running, day of rest, however you do it. But generally not running Monday to Friday and Monday to Sunday. So you can run, but potentially you need a plan of how you're going to get there. It's not just go out and run. You need a plan of how you're going to progress to that. And stronger muscles will keep your joints healthy. So the muscles are the things that are going to protect the joints. They're going to give it the shock absorption. The ground reaction force has to go through something in your body. So as you land, whether it's walking or running or going upstairs, there has to be something to absorb that ground reaction force back down. So it's obviously going to go through your joints, but it's going to go through your joints more if you don't have capacity to absorb some of that force through your muscles. So it's really important to have stronger muscles as a protective around that joint. Weight management, obviously really important. Like I said, it's a tricky conversation to have because I think from our point of view, we can do all of this really, really, really well. This isn't necessarily our domain except to perhaps support and encourage, but don't make it a barrier to doing this. You don't need to lose weight to begin this process, and perhaps if you do this process you might influence this as well. Okay? So losing any amount of weight is good. It helps in reduce the inflammatory environment for the body, because if you have excess adipose fat, then it creates a more inflammatory environment in your body. It also is a mechanical load on your knees. So it can help. So this one down here, losing 10% of body weight can provide 50% of pain relief and reduce the likelihood of knee replacement. So that's a really nice stat to have for someone. 10% of body weight is not a massive, well, it can be. If someone's 100 kilos, losing 10 kilos is a lot of weight, isn't it? You know, that's hard work. But if you're saying it's losing as much as 5% of your body weight, so 5 kilos sounds a bit more manageable, can give you good response in a pain reduction. Okay, let's get you up. There's enough sitting. That's all you guys can take.